Hi, I'm Ying Low, and I'm a cardiothoracic anesthesiologist. I will be presenting the October 2025 POCUS Case of the Month for open anesthesia. This builds on the March POCUS Case of the Month, Introduction to Lung Ultrasound, and the April and July cases. If you have not already watched these videos, I encourage you to do so before viewing this case. Our patient that we'll discuss today is a 62-year-old female undergoing a bronchoscopy and EBIS. She has a 50-pack-year smoking history and undergoes CT surveillance annually, which found multiple lung lesions that were concerning for a malignancy. She did quit smoking 4 weeks ago. She does not have other medical diagnoses other than well-controlled hypertension. Question 1. What are the known complications of an EBIS-guided biopsy? Note that more than one answer may be correct. Is it A, infection, B, pneumothorax, or C, intrabronchial bleeding? The answers here include A, B, and C. In general, transbronchial biopsies, including the endobronchial ultrasound-guided biopsies, are a relatively safe procedure for most patients. However, it can sometimes lead to complications, including intrabronchial bleeding, infection, and pneumothorax. After 1.5 hours, the procedure is completed. It included biopsies of lesions in the left upper lobe and the left middle lobe along the left lung fissure. Anesthetic medications are discontinued and the patient begins to emerge. Her vital signs are displayed here. Pulse oximeter reading is 90% on 1.0 FiO2, heart rate of 105, blood pressure of 100/70. 4 out of 4 twitches on the train of 4 with sustained tetany is observed. She is making spontaneous efforts at breathing with tidal volumes reading 200 to 300 mLs and is also intermittently coughing and making multiple attempts to reach for the endotracheal tube. While not otherwise obeying commands, the team makes the decision to extubate at this point. After extubation, the heart rate and blood pressure remain unchanged, but the pulse oximeter reading drops progressively. This is despite the patient sitting upright and using 100% FiO2. A stat chest X-ray is ordered, and a point-of-care lung ultrasound is obtained while waiting for the C-arm. Before we look at the images, let's go over the diagnostic POCUS I-AIM framework. This includes identifying an indication, the image acquisition, interpretation, and medical decision-making. In this case, the indication for the lung ultrasound exam was to narrow the differential diagnosis of the patient's acute severe hypoxemia. Image acquisition was carried out in R1, L1, and R2, L2. Probe placement for lung ultrasound is illustrated here. In this case, we are looking for a suspected left pneumothorax, which could be visualized as a lung point at L2 or L1, and comparing R1 and L1, R2 and L2 for the loss of lung sliding. This is a clip showing the ultrasound of the right lung. To recap what has been discussed in previous cases, the first thing we see here are 2 ribs, each causing a rib shadow, and in between you can identify the pleural line. You can identify an A line at the bottom of the screen here. When the probe is angled perpendicular to the pleura, ultrasound waves are reflected from the air layer in the pleura, producing an image of what looks like pleural lines that lie equidistant to the true pleural line. These reverberation artifacts can continue reflecting back and cause several A lines to appear before dissipating. These A lines lie horizontally as opposed to the B lines, which are vertical artifacts that appear as echogenic lines and extend from the pleural line into the lung parenchyma. We don't see these here. They are created by discrete short-path reverberation artifacts caused by interstitial edema, increased fluid, or interlobular fibrosis. Clinically, A lines can indicate healthy aeration of the alveoli. However, A lines can also be seen in cases of pneumothorax since there will be a reflection of air at the parietal pleura, so they do not help to distinguish a pneumothorax from healthy lung. Next, we look for lung sliding. Lung sliding is a normal finding where the visceral and parietal pleura slide back and forth on one another as the patient breathes. Some people say this looks like tiny ants marching on the line. If lung sliding is not readily apparent, it can be further evaluated using M-mode. The goal of M-mode is to see if the patient has a normal seizure sign. Note that M mode showing a barcode sign and B mode showing a static pleural line provide fundamentally the same information. In other words, M mode should not be used as the gold standard for a pneumothorax evaluation, but rather as a complement to B mode if B mode is difficult to interpret. Before reaching for M mode, it's helpful to evaluate the pleural line with a linear high-frequency transducer, because low-frequency transducers often have poor spatial resolution of superficial structures. Both false negatives and positives have been documented. For an example, in this case, a false negative seashore sign was seen in the case of a true pneumothorax that appears to show a lung pulse on M mode due to transmitted cardiac oscillations. Other authors have described cases where emphysema patients with significant blebs appear to have a loss of lung sliding and barcode signs on M mode, but moving the probe around will demonstrate that finding is only in an isolated spot. To recap, note that lung sliding can be seen with both the sector array, aka phased array, and curvilinear ultrasound probes. However, it is oftentimes most easily seen with the linear probe, given that it is a shallow structure. So it is most useful to evaluate the pleural line with a high-frequency transducer first, as low-frequency transducers often have poor spatial resolution of superficial structures. And when evaluation for a pneumothorax is ambiguous with a low-frequency transducer, or if lung sliding is not readily apparent, one should reevaluate with a linear high-frequency transducer. Here's the left lung, the site where biopsies were taken. A lung point is the point where the presence of lung sliding can be seen entering into and retreating from an otherwise completely static pleural line. This represents an inner space where the normal lung, which is visualized as the area of lung sliding, is intermittently expanding into the pneumothorax, which is visualized as a static pleural line. Note that in cases of a complete lung collapse, a lung point will not be visualized. So here are the images from the left and the right lung. So we've seen the individual views and the overall impression. Question 2. Does the unilateral loss of lung sliding confirm the presence of a pneumothorax? A, yes, or B, no? The answer is B, no. Unilateral loss of lung sliding includes a differential diagnosis that includes pneumothorax and several other conditions, such as lung adhesions between the visceral and parietal pleura, emphysematous blebs, and a one-sided loss of lung aeration. To distinguish between these conditions, it helps to incorporate the clinical context and to look for more specific ultrasound findings for a pneumothorax, such as the presence of a lung point. In this case, the pretest probability is increased compared to a patient not undergoing EBUS, where there is a post-procedure pneumothorax incidence of 0.02 to 3.5%. So as we can see, there is a lung point and a loss of lung sliding on the left when we compare it to the right lung. Question 3. Which of the following rules out a pneumothorax at a given interspace? Note that more than one answer may be correct. Is it A lines, B lines, C, lung sliding, or D, lung pulse? The answers are B, C, and D. These can only be visualized when the visceral and parietal pleura are touching each other with no intervening air between them. Since a pneumothorax is an air collection between the visceral and parietal pleura, it is ruled out within a given interspace by the visualization of any of the following: B lines, lung sliding, or a lung pulse. In contrast, A lines are a nonspecific finding seen in both sonographically normal lung and in cases of pneumothorax. Question 4. Which of the following signs definitively confirms a pneumothorax at the examined interspace? Is it A, loss of lung sliding, B, a lung point, C, B lines, or D, consolidation? As previously discussed, only a lung point is pathognomonic for a pneumothorax. The loss of lung sliding can be seen in lung adhesions, emphysematous blebs, and a unilateral loss of lung aeration. B lines and consolidations are findings that suggest that a pneumothorax is unlikely to be present. Here is a suggested screening protocol published in ANA Practice in December 2024. As part of the screening protocol, the authors suggest that when screening for a pneumothorax at a given rib interspace that the probe be placed in the parasagittal plane across rib interspaces of interest, centering on the pleural line between two ribs. If rib shadows are not visible at all, there's reason to suspect a subcutaneous emphysema. If rib shadows are visible, the next thing to look for are the presence of lung sliding, lung pulse, B lines, or a lung consolidation or effusion. The presence of these signs indicate that there is unlikely to be a pneumothorax at the examined interspace. If they are not present, then the next thing to look for is a lung point. The presence of a lung point confirms the presence of a pneumothorax. If this is not visible or indeterminate, then the next question to ask is whether the exam was performed with a high-frequency probe. If it was, we can continue to reevaluate the rib interspace using M mode. On M mode, an uninterrupted seashore sign indicates that there is unlikely to be a pneumothorax present. The presence of a barcode sign includes a differential of a pneumothorax, unventilated lung, lung adhesion, or emphysematous bleb. Finally, we move on to the medical decision-making. In this case, the patient remained hemodynamically stable, and the team was not concerned about attention pneumothorax, so the patient was reintubated to give the surgical team a chance to place a left-sided chest tube. The oxygen saturation improved quite quickly, and the ventilation improved. The patient was eventually extubated in the operating room, and the chest tube was removed 2 days later. In summary, the findings that rule out a pneumothorax are lung sliding, lung pulse, B lines, consolidation, and effusion. Regarding the seashore versus barcode sign in M mode, the seashore sign sees movement between the pleura and suggests that lung sliding or a lung pulse is present. However, both false positives and false negatives have been reported. It is important to note that the lung point is the only sonographic sign that is pathognomonic for a pneumothorax. However, it will not be seen in cases of a complete lung collapse. Thank you for joining me. This concludes the Open Anesthesia POCUS Case of the Month for September 2025. Stay tuned for more in this series.